Welcome to PHC's Emerging Trends webinar. Today is December 4th, 2020. I'm Max Topper, and I say the date right up front as the facts of COVID-19 and the vaccines we are discussing today are based on today's information. It's ever changing, as we all know. December 4th. Physicians Health Center is in our 12th year of presenting this seminar series, offering continuing education credits for nurses, adjusters, and human resource professionals. Today's event is 2 CEUs and 2 HR credits, but you must stay on Zoom for the full 2 hours. Each hour, a keyword will be given, which you will need to remember when submitting your paperwork afterwards. Before starting, let me just introduce PHC's client service team, who you work with many of them. Usually when it's not a pandemic, you see them in your offices. So let me introduce Elisa Garvin, Elisa Wade.
Hi, good afternoon.
Vanessa Figueroa, Vanessa.
Hi, everyone.
And of course, most of you know Zach Rosenthal. Zach.
Hello.
Physicians Health Center is 5 occupational medical centers serving Miami-Dade, South Broward, and the Upper Keys. Our physicians, or I like to call them our OCDocs, treat work-related injuries, perform physicals, drug testing, and medical monitoring. We are now gearing up with our cities and companies for the vaccine administration once it's available. I also must congratulate 2 of our presenters today, Dr. Adam Seidner and Margaret Spence, who were both recipients of the Comp Laude Awards presented just yesterday. It was a competitive day, and I was watching, and I was really excited. And the number of attendees for this session soared from 200 to 300 after the winners were announced. On to our first panel of experts now. We're so happy to welcome Dr. Adam Seidner of the Hartford and Deborah Roy of Safetech. Dr. Seidner is Chief Medical Officer for the Hartford.
And just really quick, before we begin, there are program evaluations for this webinar, and then you will need them in order to receive your CEU credits. We will put the link in the chat box and send it to you after the event. So please make sure to complete it. Even if you're not collecting CEUs, we still would love your feedback and hope for you to complete it. And one other note, there is the prize wheel. We will be having it again for this webinar. You do need to be present for the full webinar to win a prize.
Excellent, excellent. The topic of our first session is COVID-19, employer and employee resilience. And I'm going to ask our speakers to just introduce themselves first and then go into how they got into this topic. And now it's all yours, Deb and Dr. Seidner.
Good afternoon. I'm Deb Roy, and I have been in occupational health and safety for more than 30 years. I'm both an occupational health nurse and a certified safety professional, and also have a public health background. So I have been involved in COVID-19 since the beginning this year, and provided a number of educational sessions and writings during that time. So well, let's go ahead and get started. Dr. Seidner, you want to introduce yourself first?
Sure. Adam Seidner, as mentioned, I'm the Chief Medical Officer at the Hartford. I've been involved in medicine for approximately 30 years and with the P&C industry for 24 years. I am also an occupational medicine doctor, but also did 10 years of research on vaccines. So between the combination, it kind of brought me right into this, and I do have a Master of Public Health as well. So unfortunately, it took a pandemic to get my credentials recognized.
I completely understand that. So let me go ahead and set the stage for our session this afternoon. And unfortunately, it's a difficult story to tell. At this point, during the COVID-19 pandemic, globally, there are over 65 million reported cases. And in the US alone, we have over 14 million. And In fact, it's likely that we have significantly more than that number. Keep in mind that these were reported cases. And there's a recent study that actually did some modeling based on the data that said we probably have about 8 times as many cases as we have reported. And as you can imagine, with a disease that has a significant portion of asymptomatic individuals, there's not a reason for everyone to know to get tested. So consequently, it's highly likely that number is much larger. And in fact, in any pandemic, we won't know until later what the real number is. We know what we know right now. In terms of global deaths, there are about 1.5 million. And in the US, we have over 277,000 deaths. As of yesterday, we have reported over 218,000 cases just yesterday and over 3,000 deaths. And again, those are just the ones that are reported. We have limited hospital capacity in a number of states, and we're starting to see staffing shortages in a number of hospitals as well. And so this is becoming a challenge to take care of all of the people who are ill with COVID in some parts of the country. In terms of flattening the curve, you saw on the slide at the beginning the second wave. In reality, we're still in the first wave in the US. We never got through the first wave. Some countries did. But the fact is, here in the US, we have had 3 surges so far. One in April, one in July, and the one we're in right now. And at no time during that entire period did we get below 20,000 cases a day in the US. So we never got close to 0, which is why we're still in the first wave. I want to talk a little bit about positivity and testing. When we look at positivity rates, we're really looking at, is testing available throughout the country so that we know how many cases there really are. And keep in mind, with a high rate of asymptomatic cases, that's important. That means there are people out in the community spreading the disease without ever knowing it. And when you have high positivity rates, over 5%, you don't have a good handle on what that spread is in the community. So right now, there are 45 states in the US that are above 5%. So we don't know in many communities the extent of the transmission in those communities. All we know is that there's community spread. So that's a limitation on actually turning this pandemic around. I want to talk for a minute about transmission. And for those of us who are doing this every day, that may be a topic that we're pretty comfortable with at this point. But I'm still seeing questions from health and safety professionals about the advice that they're getting. So this particular virus is a new virus. We have learned about it over time. That advice has evolved over time based on the information. And so sometimes there's confusion because the information changes. The reality is right now, we believe this disease is transmitted primarily through respiratory. So looking at droplets and aerosols, so smaller particles or droplets. In this case, that means that your exposure is through your nose and mouth primarily. And that's why our focus is on respiratory transmission. Surfaces are still a concern, but they're not a primary concern. We do know the virus can live on surfaces for some time. But most of our data is based on a laboratory setting, not on real life, meaning differences in temperature and airflow. And so we still need to pay attention to surfaces. We do need to continue to wash our hands. We do need to routinely clean surfaces, but not to the extreme. And that's really the difference. But yes, surface contamination is a concern, particularly at this time of the year when we're going into cold and flu season, because that complicates the case if someone develops symptoms that may be cold or flu when we have such transmission of COVID-19. So, so respiratory transmission is primary, surfaces or fomites are less so. And that's also why some of the controls that we're going to focus on are going to be focused on respiratory controls. I want to mention some new guidance that you may have heard from the Center for Disease Control. In the last week, there was new guidance on the amount of time that someone needs to quarantine. Let me back up a minute and say, remember, there's a difference between isolation and quarantine. Isolation is for people who are positive or presumed positive for COVID-19, and quarantine is for those who have been close contacts of those individuals. So those close contacts are what we're talking about when we're talking about quarantine. In that case, the guidance has been all along that you need to quarantine for 14 days. That guidance remains the same. What CDC has done is looked at some of the data and done a risk assessment and said, based on the data, there is a small number of residual risk if indeed we actually let people out of quarantine sooner. So that time window, based on the data, shrinks a little bit from the 14 days, but the guidance is still 14 days. So it shrinks down to 10 days without a test, presuming that someone doesn't have any symptoms, and they will continue to evaluate for the next several days whether or not they develop symptoms. So they still have to pay attention to their symptoms during the remaining 4 days. So 10 days without testing is the new quarantine reduction. And with that reduction to 10 days, there's a residual risk of about 1%. And depending on the data, that can go up to 10%. So, but 1% is what we're looking at. In other words, 99% of the people would be able to leave quarantine at 10 days and still not become positive and spread the disease to others. Now, they also have a testing methodology that has been added to that, and that is at 7 days. So here's the way this would work. If you were quarantining and you got to day 5 and you could get a test and you could get your results back in 2 days, by day 7, after day 7, you could stop your quarantine if you were negative at that point. Now, here's the problem with that. That assumes that your timing was accurate to begin with and that the test was accurate. So that's a big if. The other piece of this that I will mention is that only applies in areas of the country where, guess what? There's enough testing. And remember what I said earlier is much of the country doesn't have sufficient testing. So the reality is that's going to still be a limited option for most people. And Dr. Seidner, I'm sure will talk about testing after me. The type of test makes a difference, and the timing of the testing is critical. So keep in mind that this is an option, but not a requirement. And particularly for those of you that are making policy for employers, which is, I think, most of you on the call, the fact is that there is no requirement to change that 14 days. And in fact, companies that have that policy can continue that policy the way they have. If you are in a situation where you need to get people back who have been potentially exposed as a close contact, but are not showing symptoms and are willing to continue to evaluate themselves, they're wearing masks 100% of the time in the workplace and so forth. In those circumstances, it may be safe to bring somebody back based on the fact of this data, the 1% residual risk. I will also say the 7-day residual risk is higher. It's at least 5% and maybe up to 12%. So the potential for spreading the virus is a little bit higher in those circumstances. So that's up to you as employers to determine how you want to approach this based on the residual risk. But the fact is the guidance is still 14 days. One more caveat to that. A number of states have imposed state laws regarding the 14 days. So even if you as an employer have the thought to actually change your policy, you may not be able to, depending on the state requirements. And it doesn't apply to those states that have actually developed travel restrictions that are for 14 days for quarantine. So that's completely separate from this federal guidance. So hopefully that clarifies. And I think the why is really important. We're really talking about residual risk that is considered acceptable risk by the CDC in that case. So that's the only reason that option is on the table. And then I want to talk a little bit about controls. So I'm also a safety professional. So what I'm focused on is if we have a pandemic going on and we have community spread, how do we protect workers and potentially customers and contractors in a workplace? So based on the transmission being respiratory, we really want to focus on layers of controls, okay, layers of protection. And the hierarchy of controls is what we use to evaluate that. So we start with the most protective of those. And the most protective is always going to be elimination. And elimination in this case is what many employers have done for their office settings. They've moved people to telework, and they're not exposed in the workplace because they're teleworking and they're on a computer all day. Now, that doesn't mean there aren't other risks from an ergonomic standpoint, but from a COVID risk, that eliminates the risk, at least of the workplace, doesn't eliminate the community spread. Secondly, in hierarchy of controls is generally substitution, which wouldn't apply here. It would with chemicals, for example. The next would be engineering controls. And engineering controls is really what we want to focus on for a respiratory virus. Engineering controls mean ventilation. So we want to improve ventilation in the workspace as much as possible mechanically. And the way we can do that is by increasing the fresh air in the space and diluting any virus that's in the space. And you do that by air exchanges. So bringing in fresh air and changing the air in the space, moving air in the space, and diluting it with more fresh air actually will improve that standpoint from an engineering controls. So the idea here is dilution. And that's really our primary focus. The challenge is in a lot of workplaces, the systems may not be new, and they may not be able to bring in enough fresh air to have sufficient air exchanges. There are other methods that can be used, like filtration. So the filters that are used in a commercial system can be changed out in most cases, not in all. Older systems may not have sufficient pressure to be able to use the higher efficiency filters. So the filters that are recommended, if the system can use them, is called MERV 13, MERV 13. And those are the filters that are recommended in this particular case, again, to capture some of those droplets, aerosols with the virus in that space. It reduces the load of virus in the space. You can also use HEPA filters, but most of these systems, unless they're designed that way, probably can't use HEPA filters. But you can use HEPA filters in smaller spaces that are portable, and those do help. And there's some really good information from ASHRAE. So it's ASHRAE.gov, excuse me, ASHRAE.org. So again, ASHRAE.org has good information about ventilation and about filtration. So that's our engineering control. Then we get down to administrative controls. Administrative controls are all the things we've been doing. They're the distancing, they're the putting decals on the floor so people are spaced, and staggering shifts and doing temperature checks and symptom checks and so forth. All of those things are administrative controls, educating our workforce about this exposure. And then personal protective equipment is at the bottom. Now, there's still some controversy in the field about whether or not cloth face coverings or masks are an appropriate level of PPE. Let's set aside that issue. Let's say it's an administrative control. The fact is that cloth face coverings or masks do help in this situation, both of the wearer that is potentially positive and others around them. So the key here is universal masking really is the focus, because we're reducing the dose of the virus in both cases. So the person who might be positive wearing a mask, it contains some of the droplets and aerosols that individual is actually exhaling. And in the case of the exposed, it keeps that person from inhaling the larger dose of that virus. So they do work on both sides, and they are beneficial from that standpoint. And the key term here is dose response. So the idea here is you need to reduce the dose that the individuals around the person who's positive are actually going to be exposed to. And that's the purpose of them. Whereas PPE normally is protecting the wearer from the external environment only. And that's why it's a little bit controversial in terms of terminology. But regardless, it's still a layer of protection. Okay. So I'm going to then turn it over to Dr. Seidner, and then I'll jump in a little later on. Adam?
Thank you, Deb. Very nice overview. And good December 4th to everybody. As you've heard, we are in a less than ideal position relative to COVID-19 in the US, and it'd be a whole nother webinar session to talk about why. But what I want to focus on is it's all about meaningful metrics and capabilities if we're going to do a good or better job than we have. So Deb already spoke to you about the CDC guidance on quarantine and isolation. I'm going to focus a little bit more on the testing and realize that we still have no national strategy for testing. And so when we talk about testing, there's three big areas that I'll be focused in today. And that's going to be the types of tests that are available, the quantity or how many tests are being done for a population, as well as the quality of those tests. So what are the types of tests? We really have a diagnostic test, which tells you if you have the infection, and then a surveillance test, which tells you if you had the infection. So the diagnostic test really looks at what I call antigens. Now, whether you're looking at a protein that's on the surface of the virus, or you're looking at nuclear material, still proteins. And so we've got different tests out there that will look at whether it's a surface protein or a nuclear material that we're testing for. And so the PCR, the polymerase chain reaction test that is really the gold standard right now, is looking at that nuclear material primarily. And it's an amplification process so that, you know, even there are times where you may have had the infection, but you're no longer actively infected, but there's dead virus floating around. And because we're amplifying that test, that diagnostic test, it may still be positive for some time, even though you truly aren't in a position where that virus has gotten into your system and is still replicating itself. So let's talk a little bit about viruses. Everyone probably has seen the cartoon of this COVID-19 virus that has these little red spikes sticking out of it. And that's where we're going to talk about the vaccines. They're all focused on that spike and why is it? So that S protein, a surface protein, is critical because the virus, you know, is just viable. It's not alive, but it wants to make more of itself. And the only way it can is to get into our cells or an animal cell, take over the equipment, machinery, and start reproducing itself. So how does it get into our cells? Well, that spike protein comes in contact with a receptor. In this case, for COVID-19, it's called an ACE2 receptor. And then it gains entry into our cell, takes over our machinery equipment to start reproducing itself. And so that's why a lot of the vaccines are focused on blocking the S protein. The second test, which I mentioned, is a surveillance test, and that really is the antibody test. And for the most part, until recently, it's been qualitative. Yes, you have an antibody, or no, you don't have an antibody. There are some semi-quantitative tests that are available now as well. And we're looking at also different types of testing with regard to how quickly we can get the results. So I'm going to mention some tests just because I think it's important for people to get a feel for all the different types of tests that are out there. I have no financial interest in these companies and just want to share some of the information. The collection samples, by the way, for this, most people are familiar. It's a nasal swab or a nasal pharyngeal swab. It may be saliva. In the case of the antibodies, a lot of times it's the blood that's being taken. So the CELEX test is a test that will get results back in less than 20 minutes. So that's kind of what we're looking for. What's the turnaround time? Because the PCR test right now, as it stands, may be 2 days, 5 days, a week. And by that time, you've really almost done your own quarantine. The semi-quantitative tests are out there. Siemens is one of them. They have Advia, Centaur, and the Telica COVID-2G tests that are available. Abbott also has an antigen test for COVID-19. And what's nice about or different about the Abbott test is that results are done on a card. It uses reagents, so there's no analyzer machine. So that's why it's taking so long for some of these other tests, because you get the sample, then it has to go and get run through an analyzer machine. The COVID test from Abbott doesn't require that. Becton Dickinson's another rapid test that's out there. Sophia SARS, it's an antigen FIA, which is a little different. It's looking at an antigen or protein. It's a fluorescent, the FIA stands for fluorescent immunoassay, and it does still need the B&D vector system. But usually you can get the results in 15 minutes when it's run on that machine. And then Quidel is a qualitative antigen test that's an FIA as well, the fluorescent immunoantigen, looking at a nucleocapsid protein. So again, this is just a small flavoring of what's out there, but it's important, I think, for folks to recognize that the tests are varied and look at different aspects of whether you have currently COVID-19 or have already had it. So let's talk about the quantity of tests. How much testing really needs to be done? And there's a whole bunch of numbers out there. I'll start with the high, which is the Harvard Global Health Initiative or Institute basically would like us to be doing 5 million tests per day. That's a lot. We're not near that. Others say that we need to be testing 1% of the population per week, which would be about 500,000 tests per day. Others are translating this into different numbers like 250 daily tests per 100,000 population. And then just others are saying, well, we're not doing enough testing if the positive rate is above 10%. So lots of different benchmarks in there, and somewhere in there is truth, but realize that depending on who you're talking to, they'll say we're not doing enough or we're doing adequate number of testing. So the other thing about the testing, besides how much we're doing, is how good are the tests? And so, if you look at the sensitivity and specificity of these tests, they're pretty good. They're like 96 to 100%. So that's great. Sensitivity and ability to identify disease when it's present, the ability to identify disease when it's not present, sensitivity and specificity. But when you look and apply anything to the real world, we have to start thinking a little differently. And what happens is we have to look at the prevalence of the disease in a population. And so I prefer, there's something called likelihood ratios. I like the negative and positive predictive values. So an NPV or a positive predictive value, PPV, are what's nice. And so the diagnostic test, just so you know, on the high end, maybe 30% false negative. Think about that, 1 in 3. And the antibody test, maybe 50% of the time false positive. What's that about? So we need to understand as we go forward and we try to, meet during the holidays, that because of the limitations of these tests in the real world, you really can't test yourself to get to a group function or the dining room table. And the quarantine is really the way to get things done. If you want to participate, you're going to need to truly quarantine yourself. You can't test yourself and think you're good if it's a negative test. For instance, one of the things to realize for these tests is that on day 1, if you're infected and you're asymptomatic, it's 100% false negative. You'll get a negative test, but you're not negative. And so if you have symptoms, it drops basically 38% would be false negative. So that's better, but you have symptoms. And so just be wary, it's important to get tested, but realize that we need to understand that the reason for this variability is where you're at in the disease, the collection, was the sample adequate? What's the workflow once the sample is taken? Was it properly handled and managed? Where's the window for use for this test? I just told you 100% false negative day 1. So what's the best time? That's why you're hearing 2, 3, 5 days out. And then, is the methodology for the test, whether you're using reagents or some of the machinery, being properly run? And so all of that comes together with giving us these false negatives and false positive tests. So now we're going to get into a section of vaccine, and the key word is vaccine. So another tool in the toolbox. That's what the vaccines are. It's just another tool in the toolbox. It's not a silver bullet, and everything that Deb talked to you about and all the public health measures that have been in front of you for the past 8 months still apply, even once the vaccine starts getting going. And so I wanted to talk to you just so everyone understands, and I'm going to pick on 3. There's many different platforms out there, meaning how did they develop the vaccine? And the 3 main ones I want to talk about today are the Pfizer vaccine, which is a nucleic acid-based mRNA vaccine. Messenger RNA is mRNA. So we have, this is the first of its kind, 22nd century technology. And what we have with it is a whole new vaccine type, which we have no basis on. This is the first of its kind coming for the human population. So there's 2 doses for all the tests. I'll point out one that only has 1 dose, but most of these have 2 doses anywhere from 3 to 4 weeks apart, 28 days apart. The one thing about the mRNA vaccine for Pfizer is the storage needs to be negative 70 degrees centigrade. And Deb will talk to you a little bit more about that and the logistical issues that are going to come along with that. The next platform that's out there, also an mRNA, messenger RNA vaccine, is a protein base. Now we have other vaccines that are based on this protein platform. And Moderna is really the vaccine that's being looked at right now by the FDA for EUA approval, emergency use authorization, it doesn't need to be stored as cold as the Pfizer vaccine, but it's still negative 20 degrees centigrade, but something that the medical systems and physician populations are able to manage. The third, which has really been around a lot longer, and we have a lot of history with the type of vaccine, comes from an attenuated use of another virus. And so what we're doing and what you're seeing for the most part is the adenovirus, which causes the common cold, is getting additional DNA, if you will, or RNA placed into it so that it's basically going to make a protein once exposed in our bodies. And AstraZeneca, the work being done at the UK with Cambridge, the Russian vaccine, J&J, are all using this platform. And there's plenty others, and there's other platforms, but these are the three main ones: nucleic acid, protein base, and attenuated virus. Now, what's nice about the storage for the AstraZeneca J&J vaccines is it's 2 to 8 degrees centigrade. So, that's easy to basically take care of and to know that the vaccine is still good. J&J vaccines, one to watch in this. I said all of them except this one are 2 doses. This one is 1 dose. So it'll be interesting to see what J&J comes up with once they complete their phase 3 trials and submit it. There's over 180 trials going on, and all of them really in some way, shape, or form are looking at this attachment or spike protein, the S protein that I mentioned. So keep that in mind as you go through. You're not necessarily going to have a choice and come in and say, I want the AstraZeneca vaccine. But, it's just a matter of making sure that the vaccine has been handled properly so it's effective and safe. And that's the whole idea behind all of this research. Is it safe and effective? We want to maintain the integrity of these studies, which I believe we are doing. We've got IRBs, which are institutional review boards that basically are approving these trials. We have DSMB, which are data safety monitoring boards that are looking, they know who gets placebo, who gets the real vaccine, who's getting sick, who's dying. There have been some deaths. There was a Brazil death, but it was in the placebo group, and who are getting some of the adverse events. And so they're able to tell early on, is there a problem? Do they need to stop the study? And there have been pauses, and which is totally normal to determine which part of the group that either the event has occurred in, or is it even remotely related to the vaccine at all. So we've also got the FDA, the Food and Drug Administration, that's going to weigh in and does the EUA, the emergency use approvals. And we also will be looking at the study designs. What's the methodology? What were the analytics? What were the conclusions and why? And so I just want to share with you a little bit of some of the numbers. Realize that about 20 to 30,000 people are in each of these trials. And so, the Moderna came out 94.5% effective. It's like, wow, that's amazing. Anything over, even 50%, some people get excited about. But here we are at 94.5%. Well, what was that? So there were 95 infections. 90 of them were in the placebo group. 5 of them were in the vaccine group. And so that's where they come up with the 94.5%. So just realize, 30,000 or 20,000 people, 95 infections. These are the kind of numbers that they're coming up with here. But safety and efficacy is first and foremost. Then let me talk a little bit about the vaccine flow in the development. Normally it takes 10 years. I spent 10 years and got a couple of vaccines through the FDA. We've got preclinical trials that are going on, and this is non-human, usually desktop or animal trials. Then we get into the clinical trials. That's when humans are involved. And I'll talk a little bit about the different phases because we've talked about phase 3 data getting to the FDA. And then you've got regulatory review and approval. That's what's happening at the FDA. That's what happened at the UK. Then we have manufacturing and distribution. That's important. That's where, again, the federal government can help. But we have to administer this, and who gets what, when, and where is really at the state level. So we're going to have 50 different strategies going on. They may be very similar, but there'll be some modifications. And then there's quality control. So now we've got, the manufacturer going on, and we're going to have to monitor how everyone's doing. So phase 1 in the clinical trials is the human population. We're looking then at, how much dose, how do they react, do they make a protein, et cetera. In phase 2, they're really looking at the various types of immunogenicity and toxicity. So based on the different doses, are we again getting the proteins that we want in the quantity we want, and are people not getting bad side effects? In phase 3, we're looking more for those, and that's where we are now with a lot of the vaccines. Serious adverse events are what's being watched very closely. And then there's a phase 4, which is monitoring longer term for the adverse events, as well as immunogenicity. How long, if we do make these antibodies, how long are they good for? So a lot of stuff there, I know. And let me just finish up a little bit more on vaccines. And I know Deb has a few things she'll want to add. So the manufacturing distribution, as I mentioned, the federal government offers guidance, technical support here. We have Operation Warp Speed that's going on. Is it science fiction or is it going to be science fact? Let's keep our fingers crossed, and hopefully it will be science fact. But it's very complicated. And about 3 weeks ago, New York Times did a very nice article on the Pfizer vaccine and really pointed out how complicated all of this is. And realize that enough people need to get vaccinated to achieve what we call community or herd immunity. You may have heard of herd immunity. We're not cattle, so I use the term community immunity. And so basically, I think the minimum for COVID-19 is going to be 70%, which is pretty high. And so with all of that, realize that the experiment of getting community immunity by just letting everyone get infected was done in Sweden, and they got to a whopping 7% of the population with antibodies. Obviously, far cry from the 70% that we need, so that didn't work. And the other thing that's going to be happening is there's going to be a prioritization of who gets vaccinated. I'm going to let Deb talk about that. But before I turn it back to Deb, I just wanted to mention there's a direct effect and an indirect effect from the vaccine. So the vaccine may prevent COVID-19, the disease, meaning if you're vaccinated, you won't get all of the signs and symptoms that we know and are associated with COVID-19. But part and parcel with this community immunity, the vaccine may or may not do enough to stop the transmission of SARS-CoV-2. SARS-CoV-2 is the virus. So you may not get COVID-19, doesn't mean you won't get infected and can pass it on to somebody else. You just won't get COVID-19, the disease. So I'm making a distinction there about a direct versus an indirect effect. Most vaccines will give us that indirect effect and stop the transmission of the virus, but we don't know that yet because we're so new in all of this. Deb, did you have something you wanted to add?
Before Deb gets on, I just wanted to give you guys a heads up that it's 15 minutes. So at some point you might want to open it up for Q&A and see if anybody has questions. Good. But it's all yours, Deb.
Thank you, Max. I'll be a moment and then we can turn it over. So thank you, Dr. Seidner. Just wanted to mention a little bit about the reality of the logistics. Having gone through this during H1N1, which was a very different and quite honestly, a lot less complicated process in 2009, the fact is that the logistics involved with the vaccine rollout are quite complex. And in fact, everything from the manufacturer manufacturing it to getting it to the individuals is going to be complicated. It's not going to be without twists and turns. So I think it's important to be realistic about that we have now a number of different vaccines, as was mentioned. And the fact is, if indeed you need 2 doses, which is the majority of them, you need to get 2 doses of the same brand. And so, and you need to get those doses within a certain period of time, generally about 28 days. So that's a lot of processing to actually get organized so that whoever gets the vaccine the first time gets the vaccine in the right period of time of the right brand. And already we're finding that the state plans assumed a certain number of doses. So for example, I'm in Maine, and we expected around 36,000 doses for the first batch of the Pfizer vaccine, should it be approved under emergency use authorization from FDA. The state found out a few days ago that we're only getting about 12,000 doses. And obviously that's not going to protect all of the healthcare workers in the state. Each state, as was mentioned, has their own plans for actually distributing this vaccine. The vaccine has to be transported as well as stored at a certain temperature. That is more complicated. And you have to keep track of all of those packages wherever they go. The other thing to keep in mind with the Pfizer vaccine, in addition to the issue of it being ultra cold and has to be stored that way, it actually is also only provided in lots of 1,000. So that's more complicated and requires space at the end. So larger facilities that have ultra cold freezer capability are the ones that are going to be able to store those. And that means that unlike normal vaccines for flu, where the flu vaccine is brought to areas of where people gather, in this case, individuals are going to have to go to the vaccine. Although it can be out of that ultra cold storage for a period of time, it's going to need to stay in that storage the majority of the time. So that's part of the challenge. For the other vaccines, again, 2 shots makes it more complicated, and guaranteed there will be problems with distribution. There will be problems with supply chain. And that means supply chain on the front end in manufacture, but also supply chain from the standpoint of actually administering that vaccine at the other end. So it's a complex process, 50 states, 50 different plans, some more realistic than others, and a federal system, as Dr. Seidner mentioned, which is not coordinated.
So before we go to the questions, I'm going to take 2 minutes and just talk a little bit about employers and company support for their employees. I mean, we need to recognize that this is a difficult time for many employees. A lot of anxiety is happening amongst them, and the company now, really more than employers, now need to communicate more than ever. And so policies, procedures around COVID-19, the quarantine, self-isolation that the company is going to adopt, in addition to whatever the state's mandating, the return to work PTO, sick leave options, personal leave, FMLA, how's that being looked at? ADA, EEOC, Equal Employment Opportunity Commission, privacy rules, all of this has got to be looked at by the employer. And so we need to, I think, apply empathy in all of these cases and how you approach your workers, especially if they do become positive. And on top of all this, we're really dealing with a second pandemic, what I would call crisis fatigue. And emotions are being generated from this COVID-19 pandemic. There's something called allostatic overload, when demand on our internal resources exceeds our capacity to employ our coping and resiliency skills. So as we go through, there's kind of 4 stages of crisis fatigue. Folks can read about. I think, stage 3, which is a disillusionment phase, a lot of us have entered, and we're physically and emotionally exhausted, which can manifest itself with anger and irritation or despair and so on. And the fatigue stage, basically people may withdraw, they may wind up going and exhibiting risky behaviors that they normally wouldn't. And it really is all about the cortisol and and adrenaline levels for long periods of times that folks are experiencing. So it's important to have all the resources. Employers have human resources, EAP, Employee Assistance Program. There are national call lines, counseling groups, support groups. NAMI, which is a National Alliance on Mental Illness, is out there. So really people embrace these resources so that we all can stay well. Questions?
Maxine, do you have questions for us? You're on mute.
Right. Okay, I saw one question come up a few moments ago, asking if you have had COVID, should you still be going for the vaccine?
I'll take that. The short answer is yes, because more likely than not, the antibody levels in your system aren't going to be adequate longer term. We'll learn more about people that have had COVID that wind up getting vaccinated and how their antibody responses react. I think it's important to have the conversation with your doctor as to what they recommend, but based on all the epidemiologic evidence that I've seen, again, epidemiologic evidence doesn't apply to the individual. You need to talk to your private doctors about whether to get the vaccine or not.
I would just add to that too, Max, is that we don't know what the durability is going to be of the vaccine itself. So we don't know how long that's going to protect us either. The same goes in this case. If someone had a serious case of COVID-19, they may have that more durable protection, but we don't know that yet. So there's such a range of symptomatology for people with this disease. There's no way to say one way or the other that it's protective enough. So,
and remember, I mean, most of the time when we know the vulnerable populations, we also know that at least in the acute and subacute infection, women do better than men. But when you're looking, there's something called long haulers where people have symptoms for months. It's actually women predominate that. So, all those things with regard to fatigue and respiratory shortness of breath or mental nervous issues. And that's a whole new area that we're trying to understand is why this happens. Why do some people go 6 to 8, 9 months with some of these symptoms?
Right. Now, there is a couple of other questions. One is, will employers be encouraged to require their employees to get vaccinated? And if so, are employers going to be required to pay for it? Now, I know the vaccine itself is free, but there is still a charge for administering it. So what would you say to that?
Deb, do you want me to go first or do you?
you can go first.
Thanks.
I think we're on the same page.
Right. In the next room, I got 36 attorneys. So, and that's what it's going to come down to. I don't think that, legally employers will really be able to mandate this. It might be a little bit different in the healthcare world where they can mandate vaccination. But it's going to be kind of a gray area for even healthcare workers and first responders. Because again, we're dealing with a non-traditional approved vaccine. We're dealing with an emergency use authorization. And so we'll have to just see how it plays out. With regard to who's going to cover it, again, a lot of the carriers that I've been talking to are going to be covering 100% through their group health insurance, any testing and vaccination they're associated. But again, it's going to be employer by employer policy driven.
Right. Now, here is one employee asked, should you take the vaccine if you are a positive or wait until you test negative? I think by the time this comes around, you will have already tested negative, I would think, but isn't that the answer? I mean, I don't think you would get the vaccine while you're testing positive, correct?
Yeah, I think that was the question, is that, let's say an example, let's say, for instance, you happen to be positive as the time when you're supposed to get the vaccine. Do you wait at that point or do you get it?
I would say you talk to your physician who's treating you. Generally, you don't want to give a vaccine if the body is focused on addressing the particular disease that you have at that moment.
And they're asking, I know that with a respirator, when you're fitted for the respirator, you're not supposed to have any facial hair. Mm-hmm. And they're asking, when you're wearing a regular mask, is there a difference?
There is, and the reason that you can't have facial hair for fit testing normally is because we are trying to approximate a certain fit rating of that mask when you're doing fit testing. And you don't have sufficient seal to be able to achieve that rating. We're not doing that with cloth face coverings. The cloth face coverings may be more effective if you have a seal, but the fact is that we're not actually trying to achieve a seal in that circumstance.
Right. Since the family of coronaviruses mutate naturally, how will the vaccine protect against these natural mutations?
So again, the focus right now has been on the spike protein. We have seen cases, documented cases of a reinfection, meaning people that have had one serotype of COVID-19. There was a gentleman from Hong Kong who tested positive, got all better, went to Spain and the UK, came back and was positive again, though asymptomatic. The first time he was symptomatic. Happens to be that he was hospitalized, and they did serotyping and genotyping in the Hong Kong and found out that he had a whole new strain. So there are mutations occurring, but the question is the mutation occurring to the spike protein? And that, may make the biggest difference. And that's why, again, 180 different types of vaccine studies going on, looking at different versions as to how much of that spike protein antibodies are going to be produced.
Right. We'll answer a couple of more, and then whatever we don't get to, we're going to have to respond via email. This question is for Deb. Do you anticipate the AC guidelines being adjusted to specifically recommend the number of air changes to provide a reasonable air dilution to minimize coronavirus exposure?
That was in reference to HVAC guidelines,
Yes.
so ventilation systems. And the fact is there are recommendations already from the literature for specific types of industry for the number of air exchanges. I don't anticipate that being in a regulation. What I do expect is that we will, over time, have better research specific to COVID-19. And I think we will actually see more specific guidance. But right now, the ASHRAE actually does have guidance. The American Industrial Hygiene Association also put out some guidance specific to air changes per hour. So it's important to look at the current guidance, and it should be industry specific, because depending on what the industry is, there are different levels of potential exposure that you could have. For example, if you're in a gym and you're breathing hard or you're singing, you're going to be potentially exposing more people just because of the volume of potential virus.
Right. Should a person who is currently in quarantine due to being in close contact with someone who's positive, wait for a negative result from that person in order to return to work, or can they proceed to end their quarantine? At what point can that quarantine end?
Okay, and that was what I mentioned. I mentioned this early on in the presentation. So the key is there is new guidance from CDC, but that individual who's in quarantine because they were exposed still has to do a 14-day quarantine. The fact that the source patient tests negative has nothing to do with that individual at all. That individual has their own quarantine. So whatever day that individual's quarantine start is day one. And the only time that can be reduced is if you look at the current guidance in terms of reducing to 10 days with CDC, and that would assume the employer is willing to use that guidance based on the residual risk.
I got you. Well, we do have some more questions, but I know I have to stay on a rigid schedule with this for the CEUs. So I want to thank you both so much. And you're welcome to stay with us if people have more questions at the end, or if you are not able to, we will send you the questions that came on. And Zach, I'm going to hand the program over to you so that you can introduce our next presenters, as well as remind everybody. Remember, Dr. Seidner, what did you say your keyword was?
Vaccines.
Yes.
So everyone write that down on a piece of
Not
paper because
vaccine, but
you will need that word for your program evaluation form.
Vaccine.
And we're going to put that link at the end of the event so you can fill out the program evals, but write down the first keyword is vaccine.